So we have a very interesting case here. Let me go over the history with you. We have a 64-year-old female patient with hypertension who is here with unstable angina, normal ejection fraction and a calcium score of 1559, who has a significant calcified lesion in the LAD. You'll see the angiogram very soon. Syntax score is 17, and the plan is to perform PCI of the LAD. We'll first do imaging with both OCT and IVUS and then decide on the strategy. The low threshold to go with IVL if need be. Is everybody able to hear us very well over there?
Yes, we can hear you.
Fluoro pedal.
Left side.
Fluoro.
Sine.
Okay, chase it now. Okay.
No. Multi-purpose.
So we have an EBU 3.5 6 French catheter. Why
Oh.
Let me see if I could. Yeah.
Elvish.
Elevation.
Fine.
મોટું છે થોડું વધારે.
Best.
Let's see where we are.
This will sit. થોડું કામ હતું ને તમારી પાસે એટલે કમ્ફર્ટેબલ રહેતા.
સરસ. જરા કરી લઈએ. Okay. Good. No, underneath it, yeah.
થોડો મોટો પડે છે.
થોડો મોટું છે. EBU 3 લેવું છે.
Okay.
Right? Should we take a EBU 3? I think it's probably a little oversized.
EBU 3.
Right? EBU 3, yeah.
Low wire.
So can we discuss here that why are we using EBU as our guide for this PCI? Meanwhile,
EBU, yeah. So from the right radial, our go-to guide for left coronary PCI is EBU. We initially started out using JL 3.5, but quickly learned that the support is much better with EBU shaped or extra backup guides. And can I have a flush, please, just once? Flush on. And it's interesting, but the dynamics of the support that the EBU gives from the right radial is very different than it is from the femoral.
Ajay, are you using, which guide catheter you use in this situation?
Yeah, what's your choice of guide for the LAD circumflex left main PCI?
so like you rightly said with the radial that EBU gives a good support, and in our lab also that more than I would say more than 95% cases in left side we go for EBU only.
Right.
But just for the fellows, I think they should be told then when to use which guide.
Yeah, so the only time we use a non-EBU or a JL 3.5 is when the left main is very short. And then we typically use a JL 3.5.
And another thing, I think JL is a great extra backup guide catheter for right coronary artery with a suitable origin. It acts like EBU in the right if it sits properly.
Against the wall, it's in the main. I think now it's in the
you are
main.
in.
Yeah, now we're in it. Yeah, perfect. Okay, we'll take the wire, or you want to take let's do a shot, right? Yeah.
Epicranial.
Yeah, epicardiocranial.
Arocranial.
So a lot of patients undergo a repeat revasc, and sometimes right radial may be absent. So for left radial, do you step up by half, or you still use the same size of guide, XVs?
Caudal joint.
I think
Epicaudal.
we use the same size. Do you have any different strategy?
Sir, Kamal here. Good afternoon. Yeah, sir. Sometimes, sir, we go half a size bigger when we go left because when we are coming from the left side, because of the support, probably instead of 3.5 does a better support when we are going from left radial.
Yeah, I think for diagnostics we often do that, but for guides in my practice I keep it the same.
Yeah.
And left radial is almost like, you can use the same set of guides what you use for femoral. I think
Right.
they will fit properly.
Yeah, the trajectory is very similar to femoral around the arch, right?
Yes.
Run through channel.
So what's the plans for this lesion? Imaging followed by?
Yeah, imaging followed by PCI. So we are going to see, obviously we'll go through our algorithm that we described. We're going to do both types of imaging. We're going to do OCT and IVUS to show you the difference.
Ajay, there is a lot of calcium you can see on fluoro.
Yes,
And the calcium score is 1500 plus.
cranial lesion.
So I'm expecting, 360-degree calcium at some good area at and around the lesion. She may land up with IVL,
Yeah, guide bar आएगी,
AP cordon.
yeah. I just. Maju bhi andar is branching. Yeah, let me just go to the apex there. Okay, good. Now we're good. Now let me get the guide back in. Okay, I Pachu. Let me remove the introducer needle. Wire thoda andar le le. Okay, ready? Okay. I think it's good now, right? Yeah. All right. So we want to start with IVUS.
Okay.
Yeah.
I was.
So let us suppose you don't have imaging. So how will you go ahead with this kind of lesion?
So if I did not have imaging, I would have chosen IVL here up front based on the fluoroscopic, calcium, and that would have been my default strategy. And probably the imaging is going to justify that most likely.
So IVUS first or OCT first?
IVUS first. We're doing IVUS right now. So
I think this is very discrete lesion. Why not to think about angiosculp or only scoring balloon rather than IVL?
IVUS.
Yeah, it's a good question, I think, but that will depend on imaging finding,
And Kirlo.
See, when the IVUS catheter is going very freely,
Right.
we can put an angiosculp freely in this lesion.
I think with they can see the image and see.
Okay.
Ready?
Yeah.
Okay.
बाहर आएगा?
Yep. Oh, the wire is coming back. Should we go further? Yeah, let's go further. Yeah, I think it came back. So, yeah, let's stop and go further a little bit. Yeah. So the guide is not cooperating, but let me just advance a little. Good.
Perfect.
अच्छा, वो बराबर है?
I think
Screw scout जो लिया?
Yeah, this is.
बंद करो।
Yeah, let me just.
मेरी बंद करो।
Yeah.
this is fine.
Yeah, कई देते बंद है।
चलो। बस
एक minute.
खींच on it.
Ah, that's good. Ready? Let's check. Yeah, I think that's decent, right?
Okay.
Yeah. Okay. Excellent. So you can see the nice trilaminar area there, vessel there. So we're quite a bit distal to the area of lesion, looks like. Right? Oh no, it's not moving, guys.
Here it is.
IVUS is the same position.
Yeah, it's
right?
in the same position.
Right.
It's not moving.
Okay.
Okay.
Now,
No,
No, it's not moving. No. It's not. Yeah, it's not moving. It's in the same spot.
So this is actually a common thing we've seen in our experience too with Boston equipment. So this is a learning curve, and no matter how much you do see this happen from time to time.
Yeah, we can do manual pullback too. Let's try one more time.
Still not.
No, it's not coming back. Yeah, it's not coming back.
So you can use the manual pull back, I think.
Manual pull back.
Yeah, it's not moving
Manual.
back.
Okay.
We'll try one more time, as per the recommendation.
Okay. Sir.
Okay, we're going to get a new gantry. Ready? Karna. I'm just going to hold on to this side so we don't accidentally dislodge. हाँ बराबर. नाम तो बराबर. It's coaxial. Pressure is good too.
Copy नाखेला तो.
Okay, it came back a little bit, so I'll push it in once we are ready. Okay, advance a little bit. Yeah, it has come back a little bit, so I'm going to advance. Yeah, there you go. हाँ. बस, सरस, चलो. Oh yeah, it's too far in, right? I'll bring back a little.
हाँ बस.
Allo barabar hai? Okay, good.
Started moving.
Okay. Yes, it is moving gradually, and
Moving.
yeah. Can you see IVUS over there on the screen?
Yes.
Yes, we can see.
Okay, excellent.
There's myocardial bridging there too, right?
Yep, you can see the bridge there
Yeah,
again.
Much nice.
The branch coming in there. And now we'll enter the second lesion, I think, soon. Right about there. You can see the calcium almost 200 degrees. 360 there almost for a short segment. Lots of calcium.
Almost 360.
360 there, almost. And now we will come probably to the proximal landing zone very soon.
Nodule.
Big nodule there.
Yeah.
Still 360 there.
Here the MLAs are good.
Okay, that is the very proximal LAD.
That's probably a proximal reference area.
I think so. I think right there is the proximal reference.
Calcium only you will have to.
Have to land the stent. Exactly. Now that comes the circosteum, and we will enter the left main. And then it's not a very long left main, so it should be getting the guide soon. Dr. Prasad, do you want to give us the commentary on it, please?
Yes, please. If you want to play it through. Yeah. So much of it is normal down there distally, but this is the bridge that we were talking about here. So I would say this is probably your distal reference, I think, down here. Pretty normal looking. Do you want to measure an area here, reference?
So that's our distal landing zone we are deciding, right?
Yeah, I think, yeah, that looks pretty reasonable. I think we've done lumen size, so we can do our quarter up if you want from there.
Okay.
This is vessel, yeah. So 30% plaque, so it's a good...
30%, so it's very good there, and our diameter there is 275.
I got it here. So this is your branch there. Yeah.
Oh, you see over here. Okay,
Yeah, so
good.
that's our proximal LAD. Probably come back to about here.
Okay, that seems like a decent landing zone, right?
Yeah. So do you want to just measure the length for us there? And an area? So around 28. And the reference? So around 3.
3, okay. So prox is 3, distal was
2.75.
275, right?
Yeah.
Now we are planning to do OCT. So, ready?
Any guess on calcium thickness from this?
So
See,
here we have got a calcified nodule also.
Yeah.
And recently, I think in March, we got one paper in which, with the number of, reverbation, you can guess the, thickness of the calcium even by IVUS. So they said that if you have got a one reverbation, I think it was 0.67 thickness. So it's still not validated, but they have come up with that, number of reverbation and the depth of the calcium. But again, for the depth, OCT is the answer, not IVUS.
Yeah, but this nodule seems to be a very nasty nodule.
Yeah,
engage कर दो
हाँ
Yeah.
engage करो एक scout with ले लिया
मैंने
आपने
तेज है अपने जो क्यों थे
So the
ना
जो बाहर से ना guide
हाँ
right
उसे हाँ
let me
right बाहर
engage
से
it yeah there we go.
yes
Just a second
हाँ go पहुँची
बराबर जाना लो
हाँ
AP
एक
quarter
you
करिएगा
good
set जो
pressure is good
एक
everything
मिनट।
हाँ
okay
I think you can right and I think location is good okay
Thank
ready
fluoroscopy.
हाँ
Angio
floor
co-registration
ચલો
co-registration
co-registration માં સીને કરવું પડશે.
cine करें okay
एक
I will
मिनट
see.
एक catheter
let me know
He
when
will tell.
yeah let me know when to cine I'll do that
It's a good case of demonstration of angio co-registration.
Can we see the
Cine?
OCT console?
yes
Yeah. OCT console, yeah. Beautiful image. It's a very clean image and a huge nodule there.
Can we see the OCT?
Yeah. OCT, show the, yeah.
No, it's visible.
Big nodule, a malignant nodule, I
Wow.
will say.
yes right at 20 right
Yeah. And here, it looked like calcium, but it is a thick fibrosis. This is
now
you
we
know,
narrow now
yeah,
there's a lot of calcium there
Yeah.
Some
here
calcium.
comes a branch
Yeah. And there is almost like 360-degree calcium.
Yes.
Yep.
Yes.
So the only issue is how this nodule is going to behave. If there is
Right
a
there.
360-degree calcium and nodule in that calcium, IVL can still work better.
that's true
But if it is an isolated nodule and surrounding is fibrosis or a normal segment,
Then
then,
it will-
it's a problem.
then it will kick the
Professor
nodule.
Akasaka, what is your take on it?
Yes, yes. Here is the calcium nodule, right?
Yeah.
Yeah. And yes, when we think about the wire bias, it might be very difficult to
Yeah.
ablate using yes, rotablator or orbital atherectomy, right? And also the IVL, if it is more than 180 degrees, it might be very useful. But in this calcified nodule, it might be very difficult.
And you see, Professor, this is a hilled plaque.
Yes.
Yeah, and you can see the hilled plaque area surrounding, and it is intriguing me because surrounding is fat all around here and a hilled plaque in some region. And
There is another nodule, I think, at the ostium of the LAD. If we could
and
happen.
this is again a hilled plaque with different sort
yes.
of optical appearance. So it's going to be interesting. Go with IVL.
yeah
And see how the things go.
I think we should take
IVL can straight away go in, I think.
we should take a 3
You
or
don't have
12
to dilate with balloon.
I will, yeah we'll take a 3 millimeter IVL
Yes,
balloon
yes.
so let's take a 3 or
A
12
quarter size higher, huh?
Yeah.
Samir?
Yeah, we'll treat the wall a little bit, yeah. One of the benefits of IVL is the low pressure inflation, I think, and so,
This is another nodule at the ostium of
Yeah,
LAD.
that's right.
So it will be interesting to see the impact of IVL on the, nodule. How
IVL, Ajay, should work here because the nodule area also has a lot of calcium in the other region.
right, opposite to the
Yeah. So
Yeah.
it should work.
yeah.
It should work. Let us see.
10 years back, how you have treated such a lesion?
I think we have done a lot of
Tricco.
disservice to our patients. Yeah, I feel that way. You know, more I see this, more I feel that way.
So as far as OCT is concerned, sir, where will be our landing zone? Around 10? 10 to 15? Can we measure?
We will
So
come
we
up with the
have, we have
landing.
co-registration, right?
Yeah, let us measure it.
Co-registration. क्या कर यस co-registration કેમ નથી
Co-registration કર્યું છે ને?
યસ
નથી
co-registration
કર્યું એને. કર. This is a good
processing હોય છે
landing
એમાં.
area
yeah,
actually.
post-processing.
Yeah. નથી થયું record. Okay. Unfortunately, co-registration has not been recorded, but anyways, you can see this is all area. I don't have any objection deploying anywhere in this
Right.
area.
I think we can, you
This
choose
is the best
between
area.
10 to 15, I think there will be a good landing zone.
This is also a good area.
That's a good area right there, yeah.
And this is actually the best area. Nothing interferes.
Yeah, stable plaque. So
Yeah.
ಹೌದು
Just
As far as the vessel sizing, what was the difference between IVUS and OCT? What is the, I cannot see from here, but what is the OCT vessel size?
the OCT will be lesser as compared to IVUS size. for
Sure, so it is saying at 15 if you go, what does it tell the size?
Yeah, at the point where we have kept, you can see 5.22. Nahi?
Sure.
Yeah, 2.44.
2.44, and with IVUS we got 2.6, right?
Yeah, that I think it correlates.
બસ લાવ
Yeah, 268 and 273, yeah. So 275, yeah. And that was, lumen was 268, yeah. So quarter size up from there, you're right. So 3.0 is a very good size based on our imaging for IVL especially.
even there is a calcified plaque in the left main also.
Yes, there is,
But I think areas are good, so nothing needs to be done for that.
yes. Ready?
કરું છું
What's the size of left main and also the proximal LAD? We do an distal or mid LAD which is of 3 millimeter.
No, here as per
This is the
this
left main.
lumen area, it is not 3 millimeter,
not
it
going,
is 2.6.
Wire ને લીલું અંદર.
It's an again a
guide
big
થોડું પાછું
time
આવી ગયું છે.
negatively we
Epicotal
modeled
model
RD,
guide
although it looks
ના,
big.
આમાં જતું રહીશ, વાંધો નહીં. એક મિનિટ છે ને, એક મિનિટ જરા ખુલ્લું છે અહીંથી.
Yeah.
But let me try jackhammering here.
Yeah.
Good, I think we delivered it.
right.
Just
બંધ
one sec,
કરજો
yeah,
તારી તારી બંધ કર. ઓકે
You ready? Let's see. I think we come back.
Back, huh,
right?
back.
Yeah.
બંધ કરો
Okay, hello, બરાબર? હા, ચાલો. Okay. ખોલવું નહીં પડે ને આના
ખોલવાની
વારે.
જરૂર
હા.
કોઈ
Okay.
જરૂર નહીં
Yeah, આમ તો પેલું loop છે એટલે વાંધો નહીં આવે.
Can we enlarge the angiography image?
Yeah, just one sec. Let me engage. Yeah.
So is it your practice to directly do an IVL balloon or do you pre-dilate in
Nahi,
cases and then?
બહાર આવશે તો epicotal
I think normally we should pre-dilate,
Alright.
but here the lumen was
Little-
seen
little
well
forward,
both
little
with IVUS and
diameter,
OCT,
Forward,
and there was nothing very objectionable directly pushing this balloon in.
Yeah.
Otherwise we pre-dilate because IVL
Okay,
balloon is
બરાબર.
not a forgiving balloon.
ચાલો.
It is difficult balloon to track many times.
Okay.
Yes.
Wow, look at that.
Yeah, you are
Okay.
spotted nodule.
Yeah, save that fluoro.
Save it.
Yeah. આ fluoro save કરજો. અચ્છા.
Can we enlarge the fluoros image?
Okay.
It's gone. no?
It's gone already. It already
Gone,
dilated.
yeah.
Already dilated.
What's the size of IVL balloon?
3.0 by 12.
6
No, that's 6. અચ્છા. જોઈજો પફ કરીને કે કઈ પરફોરેશન કેવું નથી ને.
માઇક
જોઈજો.
In this case, we were lucky like there is not much
Very
discrepancy
partial.
between the proximal and distal diameters. But if there is a lot of discrepancy, say
Ajay,
3.5 for the
Ajay,
proximal and 2.5 for the distal, How would you size the IVL balloon? For the proximal or for the distal?
See, in any case, IVL balloon, you are not inflating at above 6 atmospheric pressure, not above nominal pressure. So even if you are choosing a higher size, I don't think that it's going to be much of the problem. So if you feel that there is too much of discrepancy here, you know, at least my practice is to go on a little higher side. What do you think of it?
I would agree. I think if there's major discrepancy, like from say 3 to 4.5, then obviously, you know, you got to think. But that small amount of discrepancy, you go for the higher size.
Let's do there. We're going to go a little forward and backward and treat more, because we still think at the bottom end of the balloon there is a little under expansion.
Agreed. So they say as far as IVL is concerned, the size should be 1:1 with the reference vessel. And again, it's an application balloon. It's not a therapy balloon. So it is there just to deliver the therapy.
Okay, good.
What's the size of LED at the nodule site, the proximal one?
I think it is 2.6 as per
No. 3 is distal and it must be more than 3 over here.
So how many pulses have we delivered so far?
40. This is going to be the 50 run. We are treating it multiple times because of the imaging that we saw, Normally, angiographically, we would have stopped by now, saying, okay, it's good enough. We want to treat the proximal a little more, right? Let me come, proximal nodule we have to treat. It is very dirty,
So moreover, they say that if you want to treat the 360 calcium, you have to give 2 cycles at that place with the 360 arc of the calcium.
That's good.
You see some nodule.
Yeah, the bottom is still sticking in. Yeah, the bottom is still, has got an indentation. So I think that's where the problem is remaining. But hopefully that'll stretch,
So you can give 2 cycles there to see the impact of IVL.
Okay. So we go a little forward.
So Samir, do you actually position, because the emitters are in the proximal 2/3, right?
Okay, I think we caught that between the two transducers.
This is spot on.
Proximal nodule. Let me just simulate it just once. Okay.
How many cycles have been given by now?
There's a little bit still, but I think we should leave that little bit. There is enough lumen there, so we probably.
Pancholy, how many cycles have we given, and is there
70 pulses have been delivered.
Yeah, we gave 70 pulses.
70 and 10 is left for ostium? Ostium of the LED?
No, we're not going to touch the ostium of the LED.
Okay. There is a significant narrowing at the ostium in the OCT as well, isn't it?
There is significant calcium is also
and
seen.
Also the nodule.
Calcium.
No, I think
Okay, fine.
वायर ले लिया अंदर. Okay, चलो.
The OCT will be interesting now.
Yeah.
So have you treated the ostial LED also?
No.
So ostial LED, there was a calcified nodule and there was, MLA was also less. I think it was around 3.
Can we just show the IVUS, because we're measuring a cross-section area of about 8.9 of the true ostium.
अच्छा गाइड तो शेंगे थे वायर थोड़ा पाछड़ दे पण नदी गाइड नदी पाछड़ एंगे थे अच्छा जरा पुश अच्छा पुल अप करो जो लाई जाए बराबर वायर जरा नाके नाके दो एपेक्स में
This is the true,
yes ना गाइडिंग से करो कोर्स
हां कर दिए
This one?
एक मिनट हवे થઈ જશે થઈ ગયું થઈ ગયું
ટેક શોટ
સર કોઈ પિક્ચર લેવું છે
I think the ostial LED what it looked on OCT is probably the region near diagonal. The ostial LED has not been scanned. This time we will make sure that we scan it. But ostial LED is not objectionable as far as the IVUS is concerned.
Yeah. Ready? Sure. Hello.
Fine.
Yeah.
Jayesh, can you take one epicaudal view as
Yes.
well to look
Yeah.
for the ostial LAD?
Yeah, we'll do an LAO
LAO
caudal,
caudal.
probably we show better. By the way, in the balloon days, we'll be done by now.
Stent like PTC.
Yeah. We'll be ordering food and be very happy.
Okay.
Ready? આપણે વરસ જોઈએ પેલું પફ કરીને અચ્છા બરાબર છે ગાઈડ થોડું નાખી દો
Set નાખવું પડશે.
ગાઈડ નાખવું પડશે હા.
And these days you can get away with the DCB also.
Yeah.
The trend that is coming now.
અરે બાપરે જા આવી ગઈ અંદર જા નથી જતું અચ્છા હવે થયું હા હવે થયું બરાબર રેડી ઓકે રેડી pressure is good. I think the ostium is very good.
Ostium is
I
very
would
good.
leave it be. Yeah, ostium should be left alone.
It was not scanned in OCT actually.
Yeah,
It was
yeah.
not scanned in OCT.
Yeah, it probably jumped.
So now we scan and show the ostium LED also. Take on a survey mode, huh?
Yeah,
will
yeah. Let's show the
OCT.
fractures.
Dr. Pancholy, can we go ahead for the imaging now to look for
Yes.
how
Yeah.
effective it is
We are absolutely.
to modify the lesion?
Yes, sir. We are doing exactly that. We're going to do OCT now again, and hopefully we'll be able to demonstrate some fractures and everything.
And also the reassessment of the ostial LED.
Yes, yes. પાછું cranial માં જવું છે કે અહીંયા જવું
ના cranial માં જતો.
અચ્છા.
અચ્છા તમારું પેલું guiding નું પેલું backup માટે
ખાતા
જોઈ લો
જો
અહીંયા.
કે ostium બતાવો હોય તો અહીંયા નહીં. Let's stay here because we can show the ostium. Co-registration થાય તો.
હા.
Right?
Co-registration.
Uh,
Do angio co-registration this time, yeah.
એમાં 3 માર્કર માટે કદાચ ROV માર્ક છે. જોઈ લઈએ લેટેસ્ટ.
Just a second, let me થોડું fight કરે છે.
બે સાથે પુશ કરવું પડશે મારે.
You have to
આપણે let's go cranial rather than
yeah, go
Cranial.
to cranial
yeah, let's
view.
go cranial. Yeah. Slowly and
There is.
steadily it's going.
Yes,
Yeah.
yes. Okay.
Good. Okay, just a second.
Yeah.
Bas, bas,
I
it
think
has
that's
reached-
perfect.
it
That's
has
perfect.
reached.
Now angio co-registration, yes.
Ready? Yes. So let me know. Yeah, let me know when you want me to
Yeah,
see.
you have to go for cine.
Yeah, cine. Yeah.
No, whenever you
Yeah, whenever he says, I will start. Yeah.
Can we enlarge the OCT image?
Cine?
Okay.
Yeah.
Cine.
Cine.
Yeah,
Inject ચાલુ જ છે પણ બહુ મોડું મૂવમેન્ટ આવી બીજો એક લેવો પડશે.
Second view. Yeah, it
No,
is
it's
too
a-
distal.
ના લેટ મૂવમેન્ટ. Movement was started late.
Only the proximal area has not come out well.
Distal area is good. Proximal માટે લઈએ.
Okay, good.
Angio co-registration માં આમાં કઈ બહુ મજા નહીં આવે.
Ready?
ના કહેજે હા. હા.
Yeah.
Cine નું કહેજો.
Cine. 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 Inject.
That's
Beautiful.
better. That's better.
That's a perfect.
That's
image.
perfect.
Proximal eye.
Image and બધું we got everything.
I think we got good fractures.
Yes.
હવે જવું છે? Yeah. So we are doing angio co-registration now. Yes.
Even without stent, artery is looking good.
Yes.
Yeah. A calcified lesion, if you get a good result with balloon, you know, normally it doesn't recoil because there is hardly any elastic tissue to recoil.
That is true.
So the MLA was 1.25 to start
Nothing
with, and your luminogram is showing a good opening up of the artery.
Yeah. See, this is the distal area. Here, from here, the angio co-registration, you can see I am moving manually. So all area. The mechanism is microfracture. Some microfractures you can see here at 8 o'clock position.
Yes.
Some dissection. What is this? This is a branch, I think. Yeah.
Yep.
And again, this is a big dissection and some hematoma. It's a big medial dissection
Yes.
and some hematoma. Again here, there is a lot of demolition.
So there is
And
one
this
fracture.
this looks like a balloon fracture, macro fracture.
Yes,
a
that's
big-
a big rent,
yeah.
yeah.
This looks like a balloon fracture.
So it looks like IVL has done microfracturing but not visible. There you see
Now,
something.
yeah, there are multiple
yeah.
micro fractures.
There you can see at
At
5 o'clock.
5 o'clock,
5 o'clock,
at
6 o'clock.
6 o'clock, a lot.
Yep. 8 o'clock.
Even 4 o'clock, 5 o'clock, yeah.
Yeah, right there.
It's a big macro fracture again. So, I have a question for Professor Akasaka. Do you think that somewhere here, like macrofracture area,
Yeah.
you can see, let me come to that area properly. Somewhere here, all these area, the macrofracture, this is my hypothesis, I don't know, but macrofracture happening in a calcium like this with IVL, with a low pressure balloon where we inflate only at 4 and 6 atmosphere, could it be this soft material which is necrotic inside the calcium, which we say necrotic areas?
True.
Yeah. That's right.
Otherwise there is
Yeah.
no reason why this type of fracture should happen.
Yeah.
Like here,
Here
you can see.
You can identify,
Yeah.
yes, fracture, yes. Yes.
Big fracture,
Yeah.
and these are the soft areas. That's why it is a big fracture. Even look at the one.
But the thickness
So-
of the calcium is not so thick in this area, right?
Yeah.
Yeah.
And in this case, even Samir, it is our experience that you don't even have to do dilatation with balloon, simply stent it and then evaluate. Everything
true.
will look great.
That's true, yeah.
Yeah.
Could you
This
s-
is a nodule
Yeah, nodule, right?
at diagonal.
Yeah. So,
This nodule will give a little bit
Of our time.
objectionable appearance of the stent, but it is in the area of diagonal. You can go at a little higher pressure, no problem. If at all something goes wrong, it will go wrong on the septal side. But whenever the nodule is on the septal side,
Then it's
I
a
am
problem.
scared of going at a high pressure.
yes.
What is your opinion regarding giving the last one cycle over this nodule?
This one,
Yes.
this is not a good nodule. This is not a good nodule. It may not
Expand.
be buried inside.
Okay.
Or in the process of burying it inside, we may compromise a little bit with the
Diagonal.
diagonal,
Diagonal.
but that is all right.
Yeah,
Now
it's-
just take the size and then accordingly we can go ahead.
So Dr. Tejas, they say that whenever you use IVL,
Yeah.
70% of time you will be able to see fractures on IVUS and OCT. 30% these are micro fractures
Yeah.
that can be seen only with micro CTs.
Yeah.
And they say that, again, the IVL is application balloon. The pulses that it gives, it's a 50 atmospheric pressure.
Yeah.
So that is why these kind of big fractures, and these are multiplanar fractures. They are not in a single plane. You will see longitudinal transfer, multiple type of
yeah,
fractures.
that's right.
Yeah. And that will increase the compliance of the vessel and you will
Yeah.
get a good MSAs.
Yeah. There is one theory that, surrounding tissue gets fractured and the
3, 9,
nodule
4.
can be, pushed inside.
Approximately
But
4.
for me, it is not a very swallowable theory.
So Dr. Tejas, we did one study in which we, treated around 50 nodules with IVL.
Okay.
So our observation was that around 70% of time you will get fracture at the base of nodule, and after IVL you will get a bit of decrease in the lumen area. But that pulverizes the calcium and
Distal
that gives us a
2.9?
good MSA after putting a stent.
So
Yeah,
275,
yeah, that's
distal
right.
2.9 EEL, right? So you take 275.
What is the length?
What is the length?
Yes. What is the proximal diameter and distal one?
4 and a 2.9.
At Pancholy, will you like to
2.9.
dilate
So
at
we can
this?
take 3.5.
Two stents.
2 stents.
We have two stent strategy.
So 275 distal we
Yeah,
put
yeah,
and
that's right.
at high pressure, and then proximal will take 3.5.
Length, what is the length?
53 total.
52, so you can take a 28 millimeter.
Yeah, we can take 28 and then whatever's left we'll do it.
2.75, 28 Giants Alpine.
That is a good stent, yes. As far as, dilating it again with the balloon right now, I think with the OCT showing very good expansion, I don't see a benefit of it. I don't think there's a drawback of dilating, but I don't think there's going to be a big benefit. What do you guys think, right?
Absolutely, absolutely. Abhiram, what do you think?
Yeah, I mean, this is a really big lumen.
I think so. The only part that I'm a little bit less than happy is that bottom indentation on the IVL balloon. I think that might be the nodule. Yeah, but that's okay. That's okay.
Number one, number two, you will have a challenge
It's not big enough.
you will have challenge at at 10 and at across the diagonal for stent expansion, I think.
Exactly.
Yeah.
And I think, one of the point that I was talking to Dr. Prasad about at lunch is that, we always see these subtle things on angiogram once you start doing imaging. The angiogram has enough information, we just don't see it.
Yeah.
And once you do imaging, the angiogram becomes more informative.
And Samir, let me tell you one thing, like this indentation, if it would have been big, and if the surrounding tissue was fibrotic or a relatively healthy tissue, I would have left that indentation alone, rather than covering it with the stent.
I think it's good there. Right?
So what is the
Right?
size of this stent?
2.75 by 28 Giants Alpine.
Perfect.
Perfect.
I think it's good spot distally, landing
Perfect,
zone.
perfect.
Yep. Going up and
I'm at 6, 7, 8,
looks good. Motto.
10. Proximal line up.
Proximal anchor.
11. Okay.
Yeah. So we just came right inside the stent and we're going to do another inflation
12,
at
14,
15,
15,
14,
18.
18. Okay, good. Wow, that's huge.
Size is really a
Yeah. Okay, I'll come back out. Just a second. Perforation, nothing. Okay.
Size
Picture lives.
levani thi.
Size. Yeah, we'll get the size. Yep. And right there, right? Overlap. There's 2 millimeter overlap.
I
So
just see the caudal view there.
yeah. Okay. Sinelio.
Okay. Distal dekhi.
Yeah. Sorry.
Distal is perfect.
Distal is perfect. Yeah.
And now
here caudal.
AP caudal.
I think distal we have like 3 or 4 millimeter overlap. Huh? So we can do a little less too.
Now
Right.
just fluoro.
Just, yeah.
Cine
Cine,
मत
okay.
पैटर्न नहीं देखा बराबर.
I think it is not a bad idea.
I think this is not a bad idea to cover all the way. Yeah.
Here you can take a 3.5 stent, huh?
3528, right?
28, yes.
Yeah, this is good.
Okay.
No, 28 will be little bigger, huh? There is a lot of overlap there.
Do you want to take about
Go
24?
to AP cranial and see. I think
Because
28
I think 28 is enough.
28 is bigger, I think.
Oh, there is overlap of around 10 mm, I think.
Yeah, it's a lot big overlap.
Yeah.
23 is good enough, I think.
23.
23 is perfect.
Yeah.
3.5 by 23.
बराबर.
We have a lot of room proximally
See,
to,
Ajay, in this case, if the artery is very tortuous, I don't mind taking 28 because when the segment becomes, it straightens out, at times the stent is short. You realize that. Here it was a straight artery, so 1:1 is fine.
So it's a 3.523 you are taking?
Yes,
Yep,
yes.
yep. 23, what are signs are?
One of the advantage of using IVL over rotational atherectomy is, the CAT disrupt 3, they showed us that the chances of no flow, reflow, and perforation is much lower as compared to, that of rotational atherectomy. Because they say that it actually pulverizes the calcium, it softens it, and that is how you get a good MSAs after putting a stent.
Absolutely. I think it has democratized calcium PCI.
Yeah, that's
You know,
right.
Everybody can do it now.
Tejas sir, what has your experience been with OP and NC? Like, how do you use, because there are certain European operators who
Frankly speaking, I tried, but I'm not very fond of that balloon.
But same here, I mean, we've tried it and it's very bulky, it's okay for proximal lesions,
Thank you, sir.
but on the whole, it's
Distally
not really a
overlap
way
છે.
out.
Proximally क्यों लगा? अपने
It
सीने
doesn't
करो।
go where it is supposed to go.
अंदर थोड़ा थोड़ा हाँ मतलब थोड़ा landing zone सारा है the true ostium has a little bit of plaque, so we're going to go a little further.
Okay.
Right, I think that's good. I think that's good. Cine?
Perfect.
Right, this is good.
Go, no problem.
Let's go.
So in the hindsight, probably 28 was still better?
No. 28 would have been a little
Bit
longer
longer.
one.
12.
The landing zone proximal would have been little bit difficult one.
हाँ 14 बराबर है, right?
15.
Cine कर दो.
That's fine.
Okay. Very nice.
See, without this imaging, all these problems are eliminated with immediate effect. You do the case and in 15 minutes you are out.
That's true. It's so true. It does, in a way, make things more complicated. But I think for the patient, it's much better. Yeah, no question.
And as far as evidence is concerned, that we have got
overlap.
evidence that we have got evidence that imaging does improve the
Yes,
outcome.
absolutely.
So
थोड़ो यहाँ थोड़ो 11 8 11 जल्लो जो ये
we all need to develop that temperament for imaging.
Fluorocell, please.
But I believe once you start doing it, it comes into practice. And if you do it routinely in most of the cases, it's very difficult to do angiography, guided PCI then.
Okay. ના અચ્છા છેલ્લું હતું એ વાંધો નહીં ચલો હવે I don't think we need to make anything else 3-5 so I'm going to come out, right?
Yeah.
Good.
And I guarantee you don't have to do anything.
And we don't have to post dilate or
OCT
anything.
run, and maybe you can take IVUS run to show both,
Right.
and then you are done.
Right, exactly.
Proximal reference diameter was 4 millimeter, isn't it?
Yeah, prox was 4, yes.
So will you like to dilate it with the 4?
Let us see with OCT how it looks, because we have gone at almost 20 atmosphere, and at 20 it becomes almost 3.9.
अच्छा પેલું ગાઈડ બરાબર છે જોઈ ના નથી અચ્છા તો એક મિનિટ લઈ લો અંદર
Okay.
અને થોડું હજુ ક્લોક કરીને લેવું પડશે અંદર અચ્છા હવે થયો બરાબર આવે છે ઓકે
લઈ લે ચલો hospital.
Beautiful.
Okay, good.
Okay. Now OCT.
I think there is
You can see that nodule part.
there is indentation, we can see it.
But it's not a good idea to chase it, hopefully.
No.
Let us see.
I think we'll see the MSA there, right? If the MSA is not horrendous, then we'll leave it be.
I think one thing we must all understand here, that as you rightly said, Dr. Pancholy, that more than 80% expansion is good, but if you have got a heavily calcified complex intervention, we should be satisfied with the absolute MSAs.
Yeah,
that's very important.
Absolutely.
So the A in MLD max opposition should be replaced with area. Is some people suggest that opposition has not shown to have bad outcomes, but area does. So
Yes, area is and MSA both. Just a sec.
Survey mode, huh?
થોડું હજુ વધારે લઈ જવું પડશે
Survey mode પર લઈ લે.
એક મિનિટ જરા હા વાયર થોડું હા ગાઈડ થોડું લઈ લો અંદર just a second. Okay.
Yes, you are in. Perfect.
Yeah, just a second. અને જરા હજુ આગળ લઈ જાઓ ને થોડું
હવે
it's going slowly but it's going anyway.
it is in. Perfect.
Not to say.
Just hold on. That's
we are
good.
there.
Okay, good. We are there.
You are
Much too far.
much
Yeah,
too
right
far.
about there, right there, right.
Cinema જોજો ને.
Yeah. Hey, minute. Just once. Let me cine. Without dye, we'll cine. But we are
was
good.
good.
I think we are good. Yeah. We'll get the distal landing zone, and then we'll see.
Here we can use the OCT also to see
Okay.
whether we have crossed the stent or not.
Yeah, we are doing OCT only.
Fluoro.
Oh,
Thank you.
are you?
Excellent. So no dissection distally, no proximally, even the nodules are compressed at 45 position, means 42, 43 position.
Wow,
the
it looks
scales
much
are
better than expected.
Perfect.
Yeah, it looks better than expected.
Diagonal.
Diagonal came, yeah.
There is a nodule there, yeah.
But the best part is it has artery is largely spherical, till now. So that is not a usual, here is a nodule.
Yeah, there was a nodule there
Yeah.
and it was not spherical there, but I think the MSA will be good. We'll go back and look at it.
So this is the typical example of, seeing the expansion using, tapering method.
Yeah. And when there is such a step down, it is
Yes.
always a good idea to use a taper
Dual,
mode.
yeah.
Yeah, can we show the taper then? Let's see.
See, this is the area, this is a nodule, but still the things look good.
What is the MSA here?
The nodule MSA
6.54.
luminary is 6.54. So very good,
It's
I think that's
97%.
Yeah.
Yeah.
very good. Professor Akasaka, any comment on this?
Yeah, congratulations on good results. Yes.
So do you expect them to do anything extra inside?
Yes, yes.
Yes or no?
Yes, yes. At the site of the nodule,
Yeah.
still nodule, but
This area?
very small, yes, amount of the calcium at the site, right? Angle is very narrow.
Yeah.
Therefore, we can get a good lumen area in this portion, right?
So will you advise something or no?
It's okay, yes.
It's okay.
Yeah, right. So,
Okay.
Very
So they will take one more run with IVUS,
IVUS, okay.
just to complete the discussion. By
Yes.
that time, I will be
Just-
ready
just
with
one
the
second.
ISR case on the opposite lab, in the opposite lab. Thank you.
so
Can we see the nodule in 3D reconstruction?
right.
So this is the typical case that shows us that even with a nodule, that IVL has got some impact over it.
Right.
So this is what we also observed that, like in that if you appropriately treat, there is misconception. I call it as a misconception that if you have got eccentric calcium, IVL will not be effective. But what we have observed that if you give adequate pulses and you predilate, you will get a good MSS even with the IVL. And the most common site, 70% of the site of fracture is the base of the nodule. And theoretically also they say that base of the nodule is the weakest point of nodular calcium.
I think, I'm not sure that it is really the microfracture at the site of the nodule, but the angle of the calcium at the site of the nodule is not so big. Therefore, if there are some the dissection the opposite side
Opposite
or
to that.
around the edge of the calcium, we can get a good enough lumen area, right? So we are not sure by OCT we cannot identify any fracture at the site
Yes,
of the nodule, right?
Professor, Dr. Julio was there with
Bhatia
us,
discussion
and what he was saying is some nodules go off, some don't go. And what he was saying is the density of the nodule might be the factor.
Yeah, calcium, at the site of the calcium, there are lots of necrotic tissue. So it depends on the type of the nodule, I think, yes.
Okay, so we're doing the IVUS now and you can see the edge of the stent there
Yes.
and the expansion looks visually very good. We measure it out and make sure position looks good too, right?
Yes.
There comes that little bridge area there, it's gone now. Okay, that's your MSA that just went by nicely. That's your MSA right there
There's the nodule there,
at
right?
1430.
Looks great.
And now we are out of the proximal stent. That was nice. Thank you. Okay, good. Can you go to 1430 and give us an area there, please? Yeah.
Here is a nodule, right?
Yep, you can see the nodule there between 6 and 8 o'clock.
So we get 6.
So 6.78. So we are using our area method now. we switch our left leg or right leg, depending on what we like, right? And so the MSA or the absolute area. Even the MSA here is definitely above 80%.
For sure.
So, yeah. So
And we
let's
have
do
got
it.
evidence also for that, that absolute MSAs are, predictor of outcome.
Exactly.
So even if we are getting good MSAs, I think that's a good job.
Almost we got more than 90%.
90%, yeah. So we are good with both methods. So let's take shots without the wire, and I think we'll go across to the other room, right? Wires back. Just 1 second. I forgot.
Cranial.
One thing, Dr. Pancholy, that we usually do in our lab, that whenever we complete the case, especially that complex case,
Yep.
we always screen our imaging till left main. Because that's very important.
Yes.
If you have treated proximal LAD, complex left, calcified lesion, it's very important to rule out guide-induced dissection at the end of the procedure by using imaging.
That is very true. You're right.
Because you will not suddenly get news in the night that, oh, I don't know what happened to the patient.
Caudal ले लिए.
Caudal.
Yeah.
Yeah, and sometimes keeping the wire between the guide and the artery before taking the last view can help you do
Number
that.
one. Number two, you have imaged your LAD till left main. Just keep an eye, when you are reviewing your, LAD, just see whether any complication is there or not.
So if you keep the wire hanging between the guide and the vessel, so you would not end up on hitting upon the contrast if
with
the
that you will not
guide
get
sucks in.
good OCT image, but you can use it.
Okay, good. Thank you, guys. Thanks for all the help. Came out good, I think.
Thank you, Dr. Pancholy.
Thank you.
Thank you, Dr. Pancholy. Excellent case.
Thank you. Yes.